Welcome to week 2 for hematology. So we are going to jump into our PowerPoints today. We have 2 to go through. So let me make sure I just share my screen and we will get started. All right. So there is the first one that we're going to start with. It is chapter 29 in the new edition called Morphologic and Distributive Leukocyte Disorders. It might be titled slightly different than that in the new edition, but that's overall the gist of what the chapter is on at any rate. So we will just put this in slideshow format. All right, so first thing that you encounter in this chapter is another discussion on absolute counts. And I know that we kind of covered this a little bit in Heme 1, but it's really significant we cover it again and that you get better at it. I think we cover it more in Heme 2 than in Heme 1, actually. So the difference, again, with what an absolute count is versus what we call relative count. So an absolute white counts are considered more clinically significant than the relative counts. So again, the relative counts are those percentages. So when you guys are doing your manual diffs in the lab and you're counting your different white cells and you're coming up with 50% neutrophils, 30% lymphocytes, those are all the relative counts. That's a percentage. That's an estimate that you're saying roughly 50% of all the cells are neutrophils. So you can see that an estimate isn't that accurate. It's just giving a representation. Whereas if we calculate an absolute count, that will actually give us the number per liter of blood that there are of cells. So that will give us an actual number. So that's why an absolute count is a little bit more clinically significant. So the way that we determine that is you're going to take the total white count that you are given by the analyzer. So the analyzer will give you a total white count and multiply it by the relative count put back into decimal format. So that's the only trick to the equation, again, is so in this example down here, I'm not sure if you can see my cursor, but in this example, it was 40% neutrophils, put it back into decimal format, and that should be 0.4. So if the total white count was 10, and the neutrophil percentage was 40%, put it back as 0.4, you go 10 times 0.4, and that will give you your absolute count of 4. And again, it's per liter of blood, so the units are times 10 to the 9th per liter. So that is how you calculate it. You definitely need to know how to do this on the exams and quizzes coming up, so be comfortable performing this. It discusses here chapter 15, which that chapter number might have changed in the new edition. That was the old edition. That chapter that covers kind of like what a CBC is and all that. It's right around chapter 15 or 16 in your book. That has reference ranges, but again, in your book there should be, I know at one point last quarter I sent out that reference range sheet with all the reference ranges on it. You can just look up that attachment that I sent last quarter with the different percentages and absolute values. So again, keep knowing both the percentages and absolute value reference ranges for all the white counts. You guys have already been doing that, so it's just continuing to do that and continuing to get to know them. So that is absolute count. Here's again a rough reference range for white cell count. That should again been on that attachment I sent. Pediatric children, different age groups will vary depending on the age group. I don't expect you guys to memorize all of those. That's just too difficult. We're in this class just going to have to memorize the adult reference ranges, but again, if you get a case study and you're working on a case study, then you should look at the pediatric ones because it will make a difference. You know, that's lookup, but on a test, we're going to reference the adult ones. If you ever get the term leukocytosis, again, that just means an increased white cell count, leukocytopenia or leukopenia, a decreased white count. So just by knowing what types of cells are increased or decreased really gives a lot of information to that provider. So it could be even as simple as knowing whether it's a viral or bacterial infection, for instance. The other part of this would be knowing when you get the term relative or absolute in front of it. So if I were to say you have a relative neutrophilia, that would mean your percentage of neutrophils is increased, the relative percent count. Whereas if I said you have an absolute neutrophilia, that is saying that the absolute neutrophil count is increased. So just by throwing that relative versus absolute term in front can tell you which specific count was the one increase, whether it was a percentage or the actual count. So alterations in granulocytes, there's lots of reasons why you might have a higher neutrophil granulocyte count or a lower one. So this is just a representation of increased neutrophil counts, what we call neutrophilia. The left column, pathologic, is referring to more disease states. The benign column is just saying, you know, it may be something happening that just shot the neutrophils up, you know, like maybe you're under a lot of stress, you're going through labor, you know, things like that. So overall, what you definitely need to remember is high neutrophil counts often go along with bacterial infections, and that's because that's their job, is to phagocytize bacteria, get rid of them. They go along with inflammatory conditions, so you see that quite a bit, different malignancies. So we'll start learning leukemias this quarter, and you'll see which ones have them high and those kind of things. So this is just a nice representation overall of high granulocyte count. A low granulocyte count, what we call neutropenia, lots of different things here too. This is just a quick snapshot. Remember, vitamin B12 folate deficiency, that's that megaloblastic anemia. Remember, in that anemia, everything's low. It's pancytopenia, so all counts are kind of low. So that would include neutrophils. Different acute infections like a viral infection would cause your lymphocytes to go high, but the neutrophils to go low. So if it was an acute viral infection, that would cause a low neutrophil count. So again, I'm not going to really test you on this. This is just informational. But there are some key words that we have to know, and these are right here. The left shift, leukoerythroblastic, and leukemoid reaction. These are words that I definitely need you to remember and take away. So a left shift is any time that we use to describe an increased immature granulocyte count. So if you were starting to see lots of bands, lots of metamyelocytes, that's a left shift, those immature granulocytes that are showing up in the blood that shouldn't be there. You should hardly ever have that many bands. It should be 0 to 5%, and then you should never have metamyelocytes or myelocytes or any of those in the blood. So anytime that those start to show up, your body is kicking out immature granulocytes for whatever condition or thing that is happening. So we would term that a left shift. The term leukoerythroblastic is often used in different malignancies that might be occurring within the patient. So the word itself is saying that you not only have a left shift, so you have those immature granulocytes, but you also have immature red blood cells, so what we call nucleated red blood cells. So you have both showing up in the blood, so a combination there of both immature cells. If you look at the word itself, leuko stands for the white cell part, erythro, of course, for the red cell part, and then blast. Blast is always telling us it's immature. So it tells you immature white cells and immature red cells. So that would be the immature granulocytes plus the nucleated red cells would be leukoerythroblastic. And then the other L word in this is leukemoid reaction. That is saying that we have a very severe bacterial infection with an exaggerated response by your body. So it's a pretty significant infection, and your body's really responding to it. And so I know in your book it'll probably discuss that the white cell count is between 25 to 50, not usually over 50. I just always say greater than 50 because they want you to get the idea that it's a really high white count. It's not just a little bit high in like 15. It's like really high, like at least 25, you know, kind of that thing and up. So I always just give the exaggerated of greater than 50 just to emphasize it's a high white count. So I know in your textbook it probably will discuss more, it's 25 to 50 in that area instead. It's okay. We just need to know it's a really markedly high white count instead. Now, the thing with leukemoid reaction is when you get a white count that's high, right away you need to figure out, okay, is this a significant infection or is this a leukemia? Because a lot of leukemias look like that. A lot of leukemias will have a really high white count with lots of immature, you know, neutrophils showing up to try to, you know, for whatever reason. So it looks similar almost on a CBC at times. And so that's when we need to figure out, okay, how do we treat this patient? Is it an infection or leukemia? It's a different treatment plan. And so there is a certain leukemia called CML, which we will learn this quarter. Basically, that leukemia looks very similar to a leukemoid reaction. They have the similar types of cells. They both have really high white counts. So they do look similar on a CBC. So there is a stain called the leukocyte alkaline phosphatase stain, LAP, that we can use to help kind of separate between them. If we do the stain, there's a whole process where you score the stain cells and all this, and you're going to learn that. We'll have a PowerPoint, I think next week, I want to say, where we will learn more on that LAP stain and how to do it. But at any rate, after you get done performing it, in CML, the LAP score will be really low, whereas in a leukemoid reaction, the LAP score is high. It's like normal to high. So you can see how that score of just that LAP stain will separate. So again, in CML, the LAP score is low, and in leukemoid reaction, it's usually high. So a normal LAP stain score would be 20 to 100. So if it's CML, it would be less than 20. If it's a leukemoid reaction, it's usually greater than 100. Sometimes it's normal, but typically greater than 100. So I definitely want you to keep that in mind as well. All right, so abnormalities that can occur inside the neutrophil, the way that they look, the morphology. So these are things that can occur and change in a neutrophil due to different conditions happening. So we can have what we call Dolly bodies, toxic granulation, vacuoles, or maybe it's undergranulated, what we call degranulation. So those are all different changes that can occur. And I think I want to say I have pictures on those. So I'm going to hang on to that thought, and I'm going to come back to it if I don't see my pictures coming up. So I think we will discuss this more on what each one of those means. So hang on to that. We'll get there. If not, I'm going to come back to the slide. I just think I do have them further in the PowerPoint. All right, other granulocyte counts, of course, the other granulocytes are eosinophils and basophils. If you remember, eosinophils and basophils, we don't have a lot of them to begin with. Eosinophils is like roughly 1 to 3%. Basophils are 0 to 1%. So we're not going to worry about low numbers of these because they're already low counts. We're going to worry more about high elevated counts of these, so what we call eosinophilia and basophilia. So eosinophilia, two major things that we see this with: allergic responses and parasitic infections. There is a leukemia that you can also see it with, which we'll get into when we learn that leukemia. And then basophilia, CML is the leukemia you see that with. There is an actual basophilic leukemia. Otherwise, you don't really see it very often. And basophils are involved a little bit in allergies as well, of course. All right, monocytosis, so increased monocyte count. Different things here. Again, monocytes do have phagocytic activity, just kind of similar to neutrophils. So you do see them with different infections, bacterial, like syphilis is a bacterial infection, parasitic infections, tuberculosis, another bacterial infection. So things of that nature. And then lymphocytes. So lymphocytosis, again, that's a good representation of a viral infection. Lymphocytes really respond to viruses to fight them off, make antibodies, that kind of thing. And then, of course, there's different leukemias that involve high lymphocyte counts. And then lymphocytopenia, HIV, very much there because HIV targets lymphocytes and destroys them, which lowers the lymphocyte count. Lupus, things like that. So again, just an overall representation here. All right, now some specific disease states. These are not things that are very common, but they're definitely things that you have to remember. We're going to go through 4 specific kind of anomalies or diseases, if you will, that people, it's usually hereditary conditions, and again, they're usually more rare, but you definitely need to know them for tests in this class, for boards, and for just future reference when working in a lab. So the first up is something we call Pelger-Hewitt anomaly. And this is involving specifically neutrophils. So what happens is, instead of your neutrophils having the normal 3 to 5 lobes, they will be under-segmented, what we call hypo-segmented, meaning they're only 2 lobes. So when you're doing your manual diff and looking at the blood under the microscope, you're going to start seeing most of their neutrophils just having this 2-lobe look to it instead of a normal 3 to 5 lobes. So it's what we call nuclear hyposegmentation. That is the key finding in Pelger-Hewitt. So they have nicknamed that pince-nez appearance. Pince-nez, I believe, if I remember correctly, refers to the old-fashioned eyeglasses, and that's what they said that the nucleus with the 2 lobes looks like, is this old-fashioned eyeglasses. I think I have a picture, yeah, right here. So that's the Pelger-Hewitt neutrophils, or the pince-nez look to them. So it kind of looks like those old-fashioned round spectacles with a little bit of the nose bridge or filament or segment there in between. So most of the neutrophils in Pelger-Hewitt would look like this. So you can see they're definitely only that hyposegmentation. They don't get more than 2 lobes. All right, going back to the slide. Now, the nice thing is for the patient, it's clinically insignificant. They probably would not know they even had this until a doctor told them. You know, their cells are going to function just fine. Their neutrophils are still going to perform the role that they should. So really, they don't have any symptoms or anything like that. It's just you're going to see it when you look at the blood. Now, the problem becomes when you start seeing cells like this, are those Pelger-Hewitt cells, or are they from like a leukemia or something else that's putting out immature-looking cells that resemble Pelger-Hewitt, what we call pseudo-Pelger-Hewitt cells? They look like it, but they're not truly Pelger-Hewitt. They're from something else that's kicking out immature cells, and that would be clinically significant because, of course, if somebody has leukemia and you're seeing more cells show up like this and it's from a leukemia, we have to treat that. We have to do something with that. Could also be different bacterial infections, drug reactions, things like that. So there are cells that sometimes resemble the Pelger-Hewitt look because they're immature in the way that they were made and kicked out soon, but they're not truly Pelger-Hewitt. Instead, they belong to a different disease state that we do need to take care of. So that's kind of the big thing with Pelger-Hewitt. There is differentiating, is it truly just a Pelger-Hewitt anomaly, which is clinically more insignificant, no worry, or is it because there's a different condition happening? All right, the other side of it, if you go to the other side, is hypersegmentation. So that's when a neutrophil's nucleus is overly segmented. So it's greater than 5 lobes, 6 or more lobes essentially to it. So you see that there. There's definitely at least, let's see, 1, 2, 3, 4, 5, 6, 7 lobes in that one in the picture. So we learned this last quarter. What we always see hypersegmented neutrophils with is megaloblastic anemias. So anytime we discuss hypersegmented neutrophils, I want you to link it still with megaloblastic anemia. Simple as that. All right, now to our next anomaly. Elder-Wiley, they're pictured there. It's again involving the neutrophil cells. So what happens in Elder-Wiley anomaly is that they have a lowered mucopolysaccharide degradation. That mucopolysaccharide are lipids. And so they're not breaking down these lipids the way that they're supposed to be. And so as a result, the lipids are building up. You get mucopolysaccharidosis, an elevated amount of those mucopolysaccharide lipids in the cytoplasm. And so all those really dark granules that you see here, those purple granules, that's the lipids that have been built up in that cell, and because that they're not breaking them down. So that is Elder-Wiley, is an elevated amount of mucopolysaccharides, what we call mucopolysaccharidosis, and they look heavily granulated cells here as a result. Chediak-Higashi is our third one here. This one was also discussed in immunology, so if you've taken the immunology course, you might have heard of this in there. Otherwise, if you haven't, no worries, you'll get there. But as far as hematology world goes, again, it's affecting mostly the neutrophil, and you see that there. And what happens here is inside these neutrophils, the lysosomes, which are granules inside the neutrophils, have fused together and become bigger, larger. So it's a fusion of granules, so you get these large lysosomes, and what they call it peroxidase positive. Peroxidase is a stain, and we're going to learn that stain next week, I believe. But it's a stain, so if you were to stain it with that, they would show up very positive with that stain. But at any rate, these large granulated lysosomes that fuse together don't function anymore. Again, in the phagocytosis process, which you should learn in immunology, there's that whole stepping process. Part of engulfing bacteria and trying to destroy them is once the neutrophil gets the bacteria inside of it, those granules release enzymes and things to destroy the bacteria. Well, in the case of Chediak-Higashi, because those lysosomes have fused together, they don't do that really anymore. They don't really release the enzymes to destroy the bacteria, so they're not destroying any bacteria. As a result, the patient is really susceptible to bacterial infections and not being able to fight them off. And so it does have a big effect on patients. We also see some other things that will go along with this, not just involving neutrophils, but involving platelets. As a result, you have risk of different bleeding disorders, things like that as well. So there's a little bit more to it than just the neutrophil, but as far as hematology world, we're just looking at how does it affect the neutrophils here in this PowerPoint. So you need to just remember Chediak-Higashi, large peroxidase positive lysosomes where they have kind of fused together. And so in the picture, you can see that they're bigger and more obvious looking than what they would normally look like in a regular neutrophil. They're not as heavily granulated as the Alder-Wiley here, but they're much bigger and you can see them. And then the fourth one out of these kind of 4 diseases was May-Hegland anomaly. In this one, you see the neutrophil there. Inside that neutrophil, right by the nucleus, is that kind of blue inclusion. That is what they call a Dolly body-like formation. A Dolly body, which I mentioned on a few slides ago, which we haven't quite got to yet, looks like that. It's a round blue inclusion. This looks just like it's a Dolly body, but it's not quite the same. It just is a look-alike. So they'll get these inclusions inside the neutrophils. And then the other parts of it, it's kind of a 3-snapshot part. You get the Dolly body-like inclusions. You will have thrombocytopenia, so again, they'll result in different bleeding. And then the platelets are very large. They're giant platelets. And actually, right next to this neutrophil in the picture is a giant platelet. So those are the 3 key characteristics of May-Hegland. I'm not going to really get much more into like the symptoms and the disease. I just want us to know the morphologic or the changes to our cells that can occur in this disorder. All right, now I mentioned these back on a different slide, toxic granulation, Dolly bodies, vacuoles. So now we're going to get into them. So toxic granulation is shown there in the picture. These are very emphasized, large-looking primary granules. So in your neutrophils, you have both primary and secondary granules. The primary granules in toxic granulation become very large and big and heavily granulated. Now, if you look at this, it looks a lot like Alder-Wiley, and it's really hard to tell them apart on a microscope. You can't. They look very similar. Alder-Wiley is a hereditary condition due to not breaking down lipids. Toxic granulation, it's due to bacterial infection. It's a very, your body's stressed response to an extreme infection or inflammation happening. And so they look alike. You can't, I mean, unless somebody really has Alder-Wiley and you know it, you could say that, but usually it's toxic granulation when you see it because Alder-Wiley is kind of rare. You will definitely encounter this at some point in your hematology career if you work in hematology department. This does get seen. It is clinically significant because, again, it belongs to an extreme infection or inflammation. So when you're doing a manual diff and you encounter these heavily looking granulated neutrophils, on that diff, you need to note toxic granulation seen. You have to make that part of your report because it's significant. So again, I mean, there's sometimes people see neutrophils and think that they're toxic. Toxic granulation will kind of slap you in the face. When you come across a neutrophil that is toxic granulation, you'll know. You'll not even doubt it. It'll be like, oh yeah, that's it. You know, I mean, if you sit there and look at a neutrophil and go, is it not? I'm not sure. It's probably not. If you're that doubtful, it's not. It's like when in doubt, chicken out. When you do see toxic granulation, it's there. It's really emphasized. It's obvious that it's overly heavily granulated. So again, it's large primary granules due to a bacterial infection. The Dolly bodies, again, are that round to blue inclusion inside on the cytoplasm of a neutrophil. So you'll see it on the cytoplasm. So as you're doing your cell counts, you have to kind of be on the lookout for any inclusions. So it'll be that round to blue, oval, blue inclusion. I've already said that. Again, it's blue because it's made of RNA. So RNA always stains blue. So it's made of RNA. It's going to be in the cytoplasm. And again, it's still associated with bacterial infections, also maybe some pregnancy complications, burns, surgical things. So it is clinically significant. Again, you would want to note that you saw Dolly bodies. And then the third change that can happen with different bacterial infections is vacuoles. You would never see vacuoles inside of a neutrophil unless there is a significant bacterial infection happening. So we will see vacuoles just normally part of monocytes. That's kind of a normal thing that happens. Monocytes can often have vacuoles, and that's okay, nothing big there. But as part of a neutrophil, that is significant, especially when you see toxic granulation as well. That's indicating, again, extreme bacterial infection. So again, clinically significant, you would make note of it. Necrobiosis is a dead granulocyte, so the nuclei will look like it's exploded. It won't even look like it's normally put together, so it'll kind of be little round, little round things without any segments connecting to it anymore. So that's just a dead granulocyte. If you start to see a bunch of them, then there's a problem that indicates there's a severe strain on your pool of them. And so something is causing that severe strain. They're getting overly used or whatever it might be. So that would be necrobiosis. Once in a while, you'll just find one and it's like, yeah, you just ignore it. But if you start to see a bunch, there's a concern there. All right, let's move into the monocyte macrophage diseases that can happen with the change in morphology. There's just two for macrophages, so these are more affecting macrophages specifically. So the first is Gaucher disease. This is a condition in which you're missing a certain enzyme that breaks down lipids, and the enzyme that they are missing is called beta-glucocerebrosidase. So because they do not have that enzyme, they can't break down the lipid glucocerebroside. So that will build up in the cell, and it will make the macrophage cytoplasm look like a crumpled tissue paper look, which you can see here in the picture, or a lot of people might call it like chicken scratch. So it's not a normal cytoplasmic feature. Again, it's a buildup of that glucocerebrosidase, or glucocerebroside lipids, because they're missing the enzyme. So I always just tell people that you need to remember the enzyme that is missing, put the G's together, Gaucher glucocerebrosidase enzyme missing. And there's the look of it. So be sure you do know the look of this macrophage cell. The other macrophage disorder is Niemann-Pick disease. In this one, they are missing the enzyme sphingomyelinase, so they're not able to break down that sphingomyelin lipid. And so that lipid accumulates wherever there's macrophages. So macrophages are throughout your tissues, your organs, spleen, liver, and so on. So it's going to accumulate throughout those. And so the way that that looks in a cell is it gets this kind of vacuolated or foamy cytoplasm look. And so you can see that there, that big cell in the center is the macrophage, and you can see the kind of the vacuolated, or what they call foamy look to the cytoplasm from the buildup of that sphingomyelin in the cell cytoplasm. So that's actually a really severe disease. If you read on it a little bit in your textbook, people that are born with this usually die by 5 or 6 years old. And when you think about how much that lipid is building up throughout their body, brain, you know, it's a significant disease. All right, and then change to your lymphocytes. The one that probably we see the most in the lab is going to be the reactive lymphocytes, or you can call them variant, or you can even just say atypical, but people usually say the word reactive. So they are pictured there below. As you can see, they're much larger than a normal lymphocyte. The cytoplasm has really extended out, and it's starting to wrap around the surrounding red cells. That is a key feature where you see that cytoplasm wrapping itself around the red cells in the area. And when it does that, it gets like this basophilic, which means dark blue tinge to it as it does that. The nucleus will still kind of stay in that oval shape. It just gets to be a larger nucleus. And then the chromatin inside the nucleus isn't as condensed because that nucleus is getting stretched out. Now, the hard part is a lot of people get reactive lymphocytes and monocytes confused. They look very similar. The key is that cytoplasm wrapping around the red cells. Reactive lymphs will do that, whereas monocytes, they'll just push the red cell out of the way. They won't wrap around it like that. So, you know, and then look at the nucleus. Usually in a lymphocyte, the nucleus tends to still stay kind of ovally, whereas in a monocyte, the nucleus is almost always indented somehow. So that's kind of some key features. Again, just that the blue tinged wrap around the red cells is probably the biggest feature of a reactive. One common disease that we see that with is infectious mono. So again, infectious mono is caused by the Epstein-Barr virus. You diagnose it in the lab usually just through a mono kit, and it's looking for a heterophil antibody that is part of that infection, and that gives us a positive result letting us know that there is mono. So in somebody that has infectious mono, you would definitely see a lot of their lymphocytes look this way. But you can see reactive lymphocytes look like this in a lot of conditions. It's the lymphocytes reacting to an infection, to something that's foreign. It could be different leukemias even. So they get to look like this in a few different things. All right, so that's it for that PowerPoint. The other PowerPoint is a brief one. It's just an introduction. This used to be a separate chapter in the older edition. I think in the new edition, they don't have this as a separate chapter anymore. I didn't see it. Maybe it is, but we just are going to go through it. It's an introduction to leukocyte neoplasms. So all that means is neoplasm is just a fancy word for malignancy. So leukemia, basically lymphomas. So the big difference is a leukemia is in the bone marrow and a lymphoma involves the lymphatic system. So the origination of where the disease starts is the difference between the two. So leukemia is bone marrow, lymphoma is your lymph system. So most of the time we have no reason, we don't know why a neoplasm or malignancy occurred. They're idiopathic, it's unknown. It's a guessing game why somebody got that leukemia or lymphoma. But there are times that we have been able to link it with different viruses especially, or maybe there's exposure to radiation or something. But there's a couple key viruses listed at the bottom. The one I definitely want you to remember, which is the Epstein-Barr virus. We just said that caused mono. Epstein-Barr causes a few different things besides mono, but it has been well linked with also resulting in Burkitt lymphoma occurring. So that's one that I definitely want you to remember. The other virus isn't one that we have never really talked about, which is the human T-cell lymphotropic virus. That's been linked with causing a T-cell leukemia or lymphoma. It just depends on where it started, which spot. But the Epstein-Barr, because that's a more common virus that we see with different diseases, definitely keep that in mind that it has been linked with causing Burkitt lymphoma. Now, as far as classification of leukemias and lymphomas, we will get into this more in the leukemia chapter, but there is two big classification systems. The first one is known as FAB, French American British, we just say FAB. They classified the leukemias based on morphology, what cells were involved, how did they look, that kind of thing. So that is the number one way that they classified their leukemias was morphology. So they relied on stains, they relied on the cells that they could determine were involved to know what leukemia it would be and how, where in that class they would put it. The other classification is WHO, World Health Organization. This is the one now that everybody uses. It's more specific. It involves a lot more to classifying than just morphology. I mean, morphology can kind of be a broad topic, whereas WHO decided, I'm going to classify the leukemias based on morphology plus chromosome translocation, so like cytogenetic stuff, which is a lot more specific, different immunology characteristics. So there's a lot more to the WHO classification. So it's a lot more specific and probably accurate. So the WHO is kind of where most things are classified through. But when we learn leukemias, we're still going to learn the FAB because I think it's important that we still know it. I know in the board certification study guide book, they still had reference to this classification system, so we are going to learn that. All right, and then oncogenes. You might have learned these in chemistry at some point, or you will this quarter in Chem 2 if you're in it. Oncogenes are just, onco stands for cancer. So these are, cancer-causing genes, essentially. Why won't this go back? Sorry. All right, so genes that are capable of causing normal cells to turn into cancer cells. So if these oncogenes have been turned on, essentially like triggered, or there's some translocation that occurred that activated it, that's when a leukemia could happen. So there's one specifically that I need you to take away and remember. It's a big one. It's for CML, which stands for chronic myeloid leukemia. There is an oncogene, ABL, that becomes fused with BCR oncogene. And when that fusion happens and involves a translocation of chromosome 9 and 22, it initiates CML. 95% of patients that have CML have had this happen, have this chromosome 9 and 22 translocation happen that resulted in them getting that leukemia. So 95% of patients, that's a pretty big amount of why it occurs. So you need to walk away knowing BCR oncogene fused with ABL, BCR ABL, resulted in the translocation of chromosome 9 and 22, and that is what we call the Philadelphia chromosome. That translocation in 9 and 22 is known as the Philadelphia chromosome. So we will reference that again when we learn CML, but for now, know this information. It's very important. And then the Burkitt lymphoma that I said earlier was a lot of times linked with Epstein-Barr. There is an oncogene here as well, the MYC on chromosome 8, that when it gets fused with chromosome 14 can result in Burkitt. I'm not going to test you on that one here. I'm more worried about the CML one for now. And then you have the opposite genes. You have what we call tumor suppressor. Just as the name implies, they're there to help fight malignancy, fight leukemias. So if you mutate that gene or turn it off, that's when, again, cancer leukemias can occur because it's not there doing its job anymore. So that kind of should make sense there. All right, so that is it for the week, just those two PowerPoints. If you need anything, as always, please feel free to reach out and ask questions. Others, have a great week, you guys.